I'd like to introduce Dr. Jason Barton. Dr. Jason Barton is a professor and Canada researcher in neurology, ophthalmology, and he's the director of the Neuro-Ophthalmology Service at the University of British Columbia in Vancouver. He's also the director of the Human Vision and Eye Movement Laboratory at the University of British Columbia. Before that, he was an assistant and associate professor of neurology at Harvard Medical School. Dr. Barton has research interests that include disorders of cortical visual processing and ocular motility and nystagmus. Some of the audience here may have trained already with Dr. Barton. He wrote many book chapters and over 80 articles. Dr. Barton is going to talk to us about Amaurosis fugax and how do ocular attacks compare to cerebral transient ischemic attacks.
Thank you, Reed. It's certainly great to see Abdulaziz Ashkenani and Suleiman Al-Kashan again. And it's a pleasure to have such intelligent and responsible residents from your country coming to work with us. It seems like quite a few years ago now. I may have been mistaken, but I sort of remember, Reid and I haven't met before, but we've communicated a lot over the internet because I also run the Canadian Neuro-Ophthalmology website, neuroophthalmology.ca, and if any of you are interested, check it out because once a month we post a case up there. And I heard Reid describe himself as average a little while ago, but let me tell you, Reid often answers my cases and he always gets the answer right. Anyway, I want to... we spent much of this morning talking about optic neuritis. I want you all to erase all that from your head right now. We're going to switch gears now and talk about another problem that's actually very common, but it's not inflammatory at all in most cases. It's ischemic. So to the other end of the age spectrum, from the young to the older. Yes, I'm not getting paid much for this from anybody, so don't worry, I'm not going to try to sell you anything. So Amaurosis fugax, we all see this, right? It's transient monocular visual loss is the definition. Transient, by strict definition, means less than 24 hours. But, let's face it, most of the times when we see this, it's only a few minutes. In fact, if it lasts more than a few hours, I'm starting to get a bit nervous that I'm really not dealing with what I think I'm dealing with. The implications of the definition are a couple of things. One, the fact that it's transient for a few minutes, very sudden onset, comes on and then gradually fades away very quickly, implies temporary vascular compromise. Right, in the vast majority. There are a few other things you have to think about, maybe a little bit of like acute angle closure with pigmentary dispersion. If it's only a couple seconds, you may want to look in the eye, make sure it's not papilledema, and this isn't a transient visual obscuration. But most of the time, somebody gives you a story that, there's something comes down like a dark curtain over their eye and then goes away after a few minutes, or patchy black spots that coalesce into complete blindness and then goes away after a few minutes. You're dealing with a vascular problem. If it's monocular, it means that it's the optic nerve or retina that's complaining. It's not your occipital lobe. Although, again, there you have to be careful that when somebody says, I have lost vision on the right side, that they're not gesturing with their hand, which usually to me, if they say, I lost vision on the right side and they're doing this, I couldn't see over here, that usually means that they had a hemifield loss. And then maybe you have to think about the occipital a little bit more. But most of the time, if they check one eye against the other, it's really just the one eye. It's a monocular optic nerve or retina ischemia. And that implies that it's an internal carotid artery, which gives rise to the ophthalmic, and its two end branches, which are the central retinal artery and the posterior ciliary arteries. So the assumption then is that it's an ophthalmic TIA. It's a transient ischemic attack in the carotid territory, another carotid TIA. And we talked about extrapolations, how, can we extrapolate from the adult to the childhood optic neuritis issues, and some of the dangers was also with the, extrapolating from the steroid treatment for our spinal cord to traumatic optic neuropathy. We do this all the time in medicine, right? When you don't have evidence, you try to figure out what's the closest thing to that, and can I then, do the same thing? And here, the scenario is that, well, we have a lot of evidence on cerebral hemispheric TIAs. Somebody comes in complaining that for a few minutes they couldn't speak or their arm went limp and numb. And maybe we can take that data and use that to guide how we treat Amaurosis fugax, because they're both due to vascular compromise, usually in the territory of the internal carotid arteries. But I want to pose two questions for you today. One is amaurosis fugax really equivalent to a cerebral TIA? And two, is it amaurosis fugax in the young the same as amaurosis fugax in the old? And what I hope is to tell you, of course, that the answer is no. It's not quite the same. So let's go through a few things. We're going to go through a bit of the epidemiology. We're going to go through a bit what you see with diagnostic testing. And we're going to go through a bit of what you see with prognosis and treatment effects, too. So the first thing I want to talk about with epidemiology is the age. The fact is actually the age distribution of amaurosis fugax is not the same as a cerebral TIA. There are actually more people. Let's see if I can get this through. Is this working? There are more people over the age of 75 who have a cerebral TIA than amaurosis fugax. So the really old tend to get the limp arm and speech problems than they get the complaint of visual loss. Whereas in the younger group, it's actually amaurosis is more common than a cerebral hemispheric TIA. The other interesting thing, too, is that there's an interesting interaction between age and gender. If you look at amaurosis fugax here, the dark symbols here are for males, and here's the age range, and the light symbols are for females. And you can see that there's a little difference here. Under age 50, there's equal numbers of males and females that have amaurosis fugax, and over age 50, though, it's overwhelmingly male. And in fact, if you look at what that means is that the female peak is actually down here in the lower age range, whereas the male peak is up here. So you might say, well, maybe that's just the way atherosclerosis works in the carotids. If you're young, it's not a gender thing. If you're older, the males can tend to take the cholesterol hit more. But on the other hand, if you look at something like retinal emboli, that's not true. Retinal emboli are a good marker for atherosclerotic plaques, and you can see that female peak out here is not reproduced here. They have the same peak here for both females and males. So it suggests that maybe there's something going on here that's actually pathogenetically a little bit different than what you're seeing for retinal emboli. If you do diagnostic studies, the first thing we all think about with amaurosis fugax is, well, better look at that carotid. If you look for stenosis, you'll find that actually there's differences here too. It's more common to find carotid stenosis in amaurosis fugax than it is to find it in a cerebral TIA. Also, if you do find it, it's actually more severe in amaurosis fugax than it is in patients with cerebral TIAs, especially in the elderly. So if you look here, for example, the degree of episodic carotid stenosis binned out here and the percentage of patients in each one, you'll find that for amaurosis fugax, the black symbols, there's actually fewer people here with moderate stenosis and a lot more with the more severe stenosis compared to the hemispheric TIAs in the gray bars. There's also, as not surprisingly though, there is an effect of age on this in amaurosis fugax, just as there is for cerebral TIAs. If you're over 50, there's an 85% chance of finding it. But if you're younger than 50, there's still about a 30% chance of finding significant carotid stenosis. And that's going to become important when you think about treatment decisions. The other place you might want to look, if you have someone that you think's got a vascular event going on, is the heart. So if you look for an embolic risk with echocardiograms, you'll find that about 22% of your amaurosis fugax patients do have an embolic risk. However, if you look for good causes of cardioemboli, they're actually far more likely to be found in people with cerebral TIAs and amaurosis fugax. And here's something from the SPAF study. If you look at the incidence of atrial fibrillation, in amaurosis fugax patients, it's only 2 in 1,000 that you're going to find it for in them. If you look at cerebral TIAs, 6%. That's a 1 to 25-fold difference. So you're far more likely to find atrial fibrillation and a good smoking gun for cardioemboli in cerebral TIAs than you are to find amaurosis fugax. The reverse of what we saw with carotid stenosis, which is more severe in amaurosis fugax than in cerebral TIAs. So, well, what's going to happen to your patient? Everybody wants to know that. So the vision has come back. Is it going to leave again? And next time it leaves, is it going to be permanent? That's not a high risk. The risk of permanent visual loss, it's an easy number. It's about 1% per year. And a number of studies have shown that. How would the risk of recurrent visual symptoms in general, even if it's permanent or transient again? Well, as it turns out, that's actually far more likely to occur in amaurosis fugax than in cerebral TIAs. And this graph breaks down into people with moderate stenosis, 50 to 69%, and those with more severe stenosis. In both, the pattern is the same. The likelihood of having another retinal event is higher in the amaurosis fugax group than in the hemispheric TIA group. But on the other hand, the likelihood of having a future cerebral event, arm numbness or speech problem, is higher in the TIA group than it is in the amaurosis fugax group. So it's kind of like what you have now is more likely what you're going to have again in the future rather than having the other kind of symptom. The risk of visual loss does vary a bit with age, we think. But there's not a lot of data here. As Annie says, we don't tend to have a lot of, young amaurosis fugax is not a common thing. But the study by Tippin in 1989 showed that of the 34 patients that they studied for at least 6 years, none of them had lost vision. So how about stroke, though? We already alluded to that you're far more likely to have recurrent visual symptoms after amaurosis fugax and far more likely to have recurrent hemispheric symptoms after a hemispheric TIA. The stroke risk, data on the stroke risk also shows similar trends. From the natural study, if you looked at people in the non-surgical arm, so this is not like natural history. It's as close to natural history as we're going to get, though, because nobody's not going to give people aspirin at the very least. But this is the people who didn't get carotid endarterectomies. We know that in amaurosis fugax, if you have less than 50% stenosis, your risk of stroke is 4%. It slightly more than doubles that if you have a higher degree of stenosis to start out with. What's interesting, though, is this graph here, where you're comparing the incidence, the cumulative rate of stroke in those patients with cerebral TIAs, that's the dark line, and those with amaurosis fugax. It's quite different. The risk over time remains at about 50% less likelihood of getting a stroke after amaurosis fugax than after cerebral TIA. The interesting thing, though, and this is the one place where actually strokes in amaurosis fugax and hemispheric TIAs are the same, and that is the risk of MI and death. These curves are actually very, very similar. The risk for both of these things, somewhere else other than your head, are actually the same. And it's often the thing we tend to forget about when we treat about amaurosis fugax and stuff is what's going on with the heart and what's the likelihood this patient's going to die. Treatment studies. Well, for aspirin, which is what we tend to put people on, there's really no data that compares untreated patients with aspirin-treated patients. And as I said, there never will be. This is at least the standard of care, the minimum standard of care is to put them on aspirin. How about carotid endarterectomy? Now, going back to the slide 2 slides ago, I told you that the risk of future stroke after amaurosis fugax is only half that you see with cerebral hemispheric TIAs. Now, what that means is that when you're calculating the benefit-risk ratio, because after all, you're going to put someone under the knife to ream out their carotid, they're going to face a risk of dying on the table or getting a stroke right during the procedure. What you're hoping is that after the procedure, they're going to have a lower rate of cumulative stroke so that after about 2 years, the risk-benefit ratio is in the favor of doing the procedure. But that's contingent upon knowing that the natural non-surgical rate is actually a significant risk of stroke, and it's 50% less for amaurosis fugax. So does it still worth it to do endarterectomy? It makes it a bit more tenuous. What you need to know is that if it is going to be benefit, is it possible that if you have an endarterectomy, your likelihood of having perioperative stroke or death is less with amaurosis fugax? Or that if you follow them for the long term, that you have a much better effect on stroke rate from CEA in amaurosis fugax than you have with cerebral TIA. Is that true? If either of those things was true, then it would make the case for still doing carotid endarterectomies very good in this condition. Well, the answers are for perioperative stroke and death rate, yes, intriguingly, it is true. The 30-day rate is about 3.6% of stroke or death for amaurosis fugax versus 7% for cerebral hemispheric TIAs. And this is from the Beneventi analysis of the NASCET data. So that does suggest that, yes, interestingly, for whatever reason, it is a slightly safer procedure in amaurosis fugax, which means that that's less risk, and the benefit-risk ratio may be not so bad. The long-term, how about beyond the 30-day rate? Is the long-term effect better? Well, we don't really know this. The retrospective data suggests that there's a 5 times lower stroke rate for amaurosis fugax than for cerebral TIA after carotid endarterectomy. But you have to put this against the fact that we also know that even if you just get aspirin, your risk for stroke afterwards is also lower. So is surgery any really improvement upon that? We don't really know. Okay, so just to summarize the whole points here now. So first thing, compared to cerebral hemispheric TIAs, amaurosis fugax has a slightly younger population. It has more frequent and severe carotid stenosis, and on the other hand, less frequent cardioembolic risk, things like atrial fibrillation. It's more than 5 times likely than cerebral TIAs to result in subsequent visual symptoms. And remember, the important figure is 1% per year rate of permanent visual loss. On the other hand, it's 50% less likely to be followed by a stroke. But both have the same risk of MI. The perioperative stroke and death rate after endarterectomy is 50% less with amaurosis fugax. And how about the age factor? Well, if you're under the age 50, compared to over age 50 with amaurosis fugax, first of all, there isn't the male preponderance, unlike the data of retinal emboli. You have a lower prevalence of carotid stenosis, and you may have a more favorable prognosis, although there's not a lot of data. However, all this suggests that maybe there's something different going on in the under 50 than the over 50 in terms of amaurosis fugax, which may not be the case for retinal emboli. Maybe they have a different pathophysiology, something a bit more benign, something like vasospasm, possibly the contentious issue of retinal migraine, rather than atherosclerotic disease. I would suggest that if we put all these things together, some of the things that explain why amaurosis fugax is different from a cerebral hemispheric TI is, one, that there are more younger patients in the mix with amaurosis fugax with a more benign condition, and two, on the other hand, the cerebral TIs have a population of older people who have a more ominous cardioembolic problem than we've seen with amaurosis fugax. And this is kind of illustrated by this figure from Meadendal, who advanced the same idea that if you have carotid disease here, arterial emboli tend to kind of follow along the margins of flow. They're more likely to end up in those small little vessels like the ophthalmic artery, whereas cardioemboli, which are these big round plaques that travel in the middle of the flow stream, are less likely to be sidetracked into a small artery like the ophthalmic at the siphon. So they're more likely to go on and end up in your hemisphere. The impact of having a more benign condition, young conditions in amaurosis fugax is one epidemiologic. This is why the age distribution is skewed. And prognostically, this might be one of the reasons why you're more likely to have recurrent visual episodes and fewer strokes after amaurosis fugax, because it's a benign condition that affects only vision that's mixed into this group. Two, the impact of lower frequency of cardioemboli means diagnostically the fact that when you average the groups out, the cerebral TIA group is also going to include a bunch of people in whom it's not this carotid that's causing the problem, it's the heart. And therefore, they actually may have much lower degrees of carotid narrowing. And when you average those out, that's why you have lower mean carotid stenosis with cerebral TIAs than with amaurosis fugax. Prognostically, having more strokes and less visual loss after cerebral TIAs than after amaurosis fugax makes sense if the cerebral TIA group has a cardioembolic component, a subpopulation that have cardioemboli as their cause. So the bottom line, though, is what are you going to do about this? Here you've got this person, you want to know, can I do something to prevent them having visual loss? Can I prevent something to prevent them having a stroke? Should you do carotid endarterectomy in your amaurosis fugax group, in your old patient who has this? Well, Oscar Beneventi's Nard, our institution, did publish these recommendations from the NASCET data, the analysis he did. He suggested that if you have less than 50% stenosis, forget it. You actually do worse with surgery. Okay, I don't think that's too contentious. If you have more than 50% stenosis, you have to hunt for a few more factors that can maybe tip the scales to providing a better benefit-risk ratio. One is if you're really old, if you're male. This one I found a little kind of curious thing, because after all, if you have a prior cerebral hemispheric stroke or TIA, you're really doing the procedure for the prior thing, not for the amaurosis fugax. But nevertheless, it's one of the criteria they used. Claudication really is a marker of just more general severe vasculopathy, I guess. More than 80% stenosis really would sway you perhaps a bit more. And also perhaps the finding of no collateral flow in angiography. So if you have 3 of those, it's probably worth doing the procedure. And if so, you find that the 3-year stroke rate decreases from 24 to 10%. Otherwise, you treat them as you would for stroke with aspirin. And again, don't forget about investigating their cardiovascular, the cardiac vessels for the risk of MI. For the young patient who has amaurosis fugax, what are you going to do with that? Well, we really don't know. Extrapolating from the young stroke experience is maybe inappropriate because a substantial proportion of these people may not really have a stroke problem. They may have a more benign vasospasm or something else. So whether that's a really fair thing to do is not really clear. When we see a young stroke in neurology, you tend to give them a full court press. You look for cardiac sources, you look for hypocoagulability, you ask them about cocaine and drug use, you look for venous things. There's a bunch of things you have to go through. You look for a lot more things than you would in the elderly. It's a much more elaborate procedure. But is that appropriate for amaurosis fugax? That's a much tougher thing. I would suggest that a tentative suggestion for living with this kind of uncertainty was, first of all, take a careful history exam for young stroke risk factors. Do they have any of those cardiac, hematologic, drug use, dissection, vascular risk things, possibilities for paradoxical emboli with patent foramens, that kind of stuff. If they have anything like that, beware. Ask them about migraine. If they have vasospasm, they might have a migraine. This is what Corbett found, was that a good number of these people with young amaurosis fugax also had a coincidental story for migraine. Of course, it doesn't mean that it's causing it, but it's associated. I do a carotid study anyway because the data suggests that 30% of these people will have some stenosis anyway, and some of those may have a critical stenosis that maybe you should think about doing something about. After you've done these things, investigate further if I find a stroke risk factor, obviously. Reassure them if there's no stroke risk factor and a positive migraine history. If you have neither of these things and you have no stenosis, observe. Question mark. And that's all I have to say.
Thank you, Jason. It's 1:40 and we are right on time. So I know many of you have questions. There'll be a panel discussion at the end of the next session, but now we'll break.